So this is an article that specifically looked at the prognostic information of procalcitonin on patients admitted with community-acquired pneumonia. So these patients admitted to the emergency room with community-acquired pneumonia, and you can see that if their procalcitonin levels were greater than 0.1, they had a higher mortality than suppose it was less than 0.1. So the idea is that procalcitonin less than 0.1 predicts a very low-risk population that could be dealt with maybe even as an outpatient or at least to a ward. The fourth area here was for monitoring to allow titration or modification of care if you're following on a daily basis or every other day. So if you're monitoring these patients utilizing procalcitonin, a major rise in procalcitonin may indicate new infection and can potentially improve the lead time to diagnose infection. So again, we've talked about how difficult it is to clinically make the diagnosis of infection, and so we potentially get lead time by a biomarker. On the other hand, if procalcitonin is improving, we're more likely to continue either the same course or even potentially de-escalate care. So as you know, in patients that have infections, 30% or more, we never actually diagnose an organism, so we don't know sensitivities. But if we know that the patient's improving, it may allow us to de-escalate to less broad-spectrum antibiotics. On the other hand, if it's not improving or even worsening, I think we have to at least consider an empiric change in our therapy or new diagnostic tests. And then the other issue is stopping antibiotics early for an early cure. Again, as you're monitoring your risk assessing these patients, there's good data now that says that even for ventilator-associated pneumonia patients, we can get by with just 8 days of antibiotics if the patients are improving. But I think we need some objective evidence that patients are truly improving. So this is our typical ICU patient. They're hooked up to multiple machines. They're laying flat on their back. They're heavily sedated. We can't do a history on them. Our physical exam becomes much less reliable. And we're trying to assess this patient on a daily basis. Is their infection getting better? Is things getting worse? Do they have a new infection? And this is a typical curve that you can look at on patients that are in the intensive care unit and have infection. So the blue curve here would show patients that get started on appropriate antibiotics, and after 3 or so days, you'll see procalcitonin levels start to fall. And we've had other patients very similar to this that come in. We think they have a particular infection. We start them on the antibiotics, and we notice their procalcitonin is not improving. It's not improving. Next thing you know, we grow out Pseudomonas, and we have not had them on anti-pseudomonal drugs. We switch antibiotics, and then we start seeing the procalcitonin level come down. Unfortunately, there are some patients that, in spite of being on good antibiotics, they may not improve, especially the immunosuppressed patients. We may know the infection, but we never get a handle on it, even with good antibiotics, because of their poor immune status. Another area in the intensive care unit is patients with fever, and of course I've been following C-reactive protein levels for a number of years, and so we struggle with these patients. Well, does this fever and high C-reactive protein level represent infection? So you can see that C-reactive protein does not really help distinguish those who have infection versus other inflammatory diseases or even malignant neoplasms. But procalcitonin does. Procalcitonin levels in the other inflammatory processes and malignant neoplasms, in general, it remains very low, and if they have infection, procalcitonin is elevated. So it helps you evaluate the patients with fever in your intensive care unit. And then finally, of the roles of biomarkers by Marshall, talked about a surrogate endpoint. So if we have a quick objective test that we know correlates with our ultimate endpoint of survival, then anything that we potentially do, we could titrate our care if that number improves. And it doesn't just have to be the treatment of infection, such as antibiotics and source control. It could be other therapies, such as nutrition therapy, physical therapy, or ventilator management. The example I would give that's out there in the literature talks specifically about enteral nutrition versus parenteral clearly improves C-reactive protein levels in pancreatitis patients, and that improvement in C-reactive protein correlated with improvement in their overall outcome. So what else is there in procalcitonin? There's a lot of articles if you just pull up procalcitonin now and do a literature search. Some of the areas that I think are important, one is differentiated infection, specifically pneumonia in patients that has ARDS. So patients already got a very, very abnormal chest x-ray, and you're trying to define, is this a new infiltrate or is this an old infiltrate, et cetera, gets very difficult. And procalcitonin potentially can be helpful in making that decision. I know in my own experience, looking at patients that have prolonged ARDS, and so we want to start steroids for, quote, late ARDS in these patients. And it's got a particular risk. It's high-dose steroids that are very immunosuppressive. In my own experience, I feel like the patients that have relatively high C-reactive protein levels but low procalcitonin levels are the ones that seem to do the best. So it seems that the higher C-reactive protein level correlates with a lot of inflammation, and that's why we're giving steroids as an anti-inflammatory agent. Yet at the same time, if you review that trial, it talks about how important it is to make sure that patients don't have ongoing infection before you start these high-dose steroids. Other articles out there talking about septic versus non-septic arthritis utilizing serum procalcitonin levels. Neutropenic patients with fever, although I would caution many neutropenic patients are often infected with something besides bacteria, and procalcitonin is much more specific for bacteria. So just because you have a low procalcitonin level in a neutropenic patient doesn't mean that they need no therapy. It just means that the likelihood of bacterial infection would be relatively low. There was a conference, and then Dr. Gluck presented some data of his own. I've not seen it in print as of yet, but it's talking about using procalcitonin to improve the sensitivity and specificity of D-dimer for diagnosing pulmonary embolism. So one of the big problems with D-dimer is when it's positive, there's multiple other areas that cause a positive D-dimer besides PE, and the most common cause would be infection. Essentially, everybody with major infection is going to have an elevated D-dimer level. So his data seemed to suggest that a very low procalcitonin level in the setting of a high D-dimer was much more specific for diagnosing pulmonary embolism. I've already mentioned steroids, high-dose steroids. Steroids do inhibit the C-reactive protein levels, and so in patients who are on high-dose steroids for whatever reason, procalcitonin can still be helpful to diagnose infection in those patients, as opposed to following C-reactive protein. There's some data in children looking at viral versus bacterial meningitis, utilizing procalcitonin to help you with that diagnosis. And then finally, if you do follow C-reactive protein levels, you have to remember that C-reactive protein is produced by the liver. It's an acute phase reactant that is produced in the liver, and patients with liver failure or major liver insufficiency, C-reactive protein becomes much less helpful as far as following to decide whether or not they have sepsis. So what about false positives? So procalcitonin release in the absence of infection. I don't deal with newborns, but apparently newborns that are within the first couple of days have very high procalcitonin values, but they drop fairly rapidly in the first few days, and after that you could use the normal adult reference ranges. The primary inflammation issues caused by trauma, extensive burns, major surgery often causes procalcitonin levels that are a little bit elevated, and when I talk about the levels, we're talking about levels kind of in that 3 to 4 range, so they're not very helpful in the first day or two as far as whether the patient has infection. However, if there's no new insult, those levels usually drop fairly rapidly within the first 3 days, and then you could follow them after that. It is of note that I think if you look at some of the old trauma data, that 10% of trauma patients who are hypotensive, if you do blood cultures on them, 10% will have positive blood cultures. So it could be that there are actual bacteria or bacterial products that are causing these elevated procalcitonin levels, but they don't have classic infection, don't necessarily need long-term antibiotics. I haven't dealt with any C-cell cancers of the thyroid, so I've not seen this one, but we do see the next one, the prolonged circulatory failure. So if we look at all of our patients that come in with cardiac arrest that we're giving hypothermia therapy to, many of these will have these mildly elevated procalcitonin levels in that 2 to 4 range for the first few days. And again, I'm not sure exactly what to do with that. We typically start antibiotics early on just because of the data about how much improvement you can make with antibiotics if you miss infection. But we'll stop them quickly at day 3 if procalcitonin levels are dropping. And then finally, we did have a patient that was getting chemotherapy. It was one of these anti-lymphocyte issues, and she went into ARDS and went onto the ventilator and had very high procalcitonin levels, although we never documented infection. And then some of the false negatives to worry about. Again, this is mostly specific for bacterial infections, so viral infections, fungal infections, parasitic infections typically don't have elevated procalcitonin levels. When we had our H1N1 outbreak, those notoriously had low procalcitonin levels. We still get occasionally an HIV patient that has pneumocystis pneumonia, and they typically have low levels of procalcitonin. The other area would be local bacterial infections. So patient comes in with an ear infection that needs antibiotics. It's unlikely their procalcitonin level is going to be elevated of significance. Could be very early in a severe bacterial infection. So if you caught a patient in the first few hours, right as their insult, you may not see an elevated procalcitonin level. But that's why one of the reasons they talk about in this, quote, first 24 hours is the trending of these patients. So just easy to repeat in the next few hours. And then finally, some of the subacute bacterial infections, subacute bacterial endocarditis. We've had a couple of patients who have had strep viridans endocarditis. One of them was a patient who actually came in as a head bleed, and we weren't sure exactly what was going on. She had some low-grade fever. We went ahead and did some cultures, but everything looked good. Procalcitonin was relatively low. We didn't start antibiotics right away, and she ultimately grew out strep viridans and had endocarditis, and aortic valve endocarditis was the cause of her small head bleed. And we had another patient that had long-term hydrocephalus that needed a ventricular peritoneal shunt. He had had repeated episodes of catheter-related meningitis. They finally brought him to the intensive care unit after taking his catheter out and just had him drained at the bedside. And he finally eventually grew out serratia from his CSF, but it was a very low indolent infection, and his procalcitonin levels stayed relatively low.